republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the November 13, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Cheryl, can you have a roll, please?
Director Eapen.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee. Present. Director Stewart.
Present. Moving on to oral communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record and then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? No? Shall any written communications? No. Good. Thanks. Go on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take an action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No. Does any member of the public want to remove an agenda item from the consent calendar? None. May I have a motion to approve the consent calendar items A? Stuart.
Mr. President, I move that the Board of Directors approve the consent calendar, item A.
Second that. Director Eapen.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee. Aye. Director Stewart.
Aye.
So we have a presentation.
Yes, I just thank you, Dr. Eapen. I just have a short presentation. As you know, every year we recognize Veterans Day, and it really gives us a chance to pause, reflect, and express our profound gratitude for the courageous individuals who have dedicated themselves to our nation's service. Originally established in 1919 and as Armistice Day to honor the end of World War I, this day has evolved in name and significance, becoming a national holiday in 1938 and later in 1954 recognized as Veterans Day. While the name may have changed, our purpose remains the same, to honor those who, through their bravery and sacrifice, have upheld the ideals of freedom, security, and democracy for all Americans. Here at Washington Hospital Healthcare System, we proudly uphold a tradition that began in 2016, dedicating a special space to recognize those who have served in the armed forces or are currently serving in the reserves within our healthcare system family. Displayed on our Veterans Recognition Wall, located in the Washington West Building, are the names, branches, ranks, and lengths of service of these individuals. I encourage each of you to take a moment to visit this commemorative wall when you are next in the Washington West Building. This tribute wall represents a cross-section of our healthcare system, employees and physicians and providers who work in our hospital, our surgery centers, Washington Township Medical Foundation clinics, and various outpatient centers. Currently, there are 113 names honored on this wall, including 3 new names added this year. The following are the people who were added to the Veterans Recognition Wall. Wayne Garrett, DO. Dr. Garrett is a pathologist who works with the hospital's pathology group, Western Laboratories Medical Group. He served in the Army for 15 years, 7 months. He achieved the rank of Lieutenant Colonel. Next is Lawrence Moore. Lawrence Moore is a staff nurse too. He served in the Army for 8 years and achieved the rank of E4 Specialist. Lastly is Dr. Chet Morrison. Dr. Morrison, many of you know Dr. Morrison, has joined our organization as the Medical Director of the Trauma Program. He served in the Army for 14 years and 4 months. He achieved the rank of Lieutenant Colonel with special training in trauma and critical care. We should all be proud of the talented veterans who are part of our healthcare system family. Our leave policy allows members of the Armed Forces or National Guard to be granted military leave from work for the period required when called to, in terms of active duty for training, inactive duty training, and active duty. We hold deep respect and gratitude for the selflessness of our veterans, whether they served in times of peace or in the face of conflict, and no matter the branch of the military in which they stood. We truly appreciate their dedication and commitment. We honor not only their service, but also the sacrifices they and their family have made to protect and uphold the values we cherish, both here at home and across distant shores. So thank you. Yes. I do want to say thank you to Mr. Mike Wallace. I know you've served, and also in the room, Larry Labossiere has also served. So thank you both very much.
Thank you.
Thank you.
Good.
Thank you.
Good.
So next is the medical staff report. We have Dr. Mark Saleh, our Chief of Staff.
Good evening, everybody.
Good evening.
Good evening.
All right, we'll start off with the medical staff census. We have a total of 656 physicians and providers, rather, on staff. Of those, about half, or 349, are active. 2 are administrative. 32 are advanced practice providers. 94 are ambulatory status. 7 are consultants. 13 are courtesy. 2 are on leave of absence. 97 are provisional active, 13 are provisional advanced practice providers, 39 provisional consulting, 7 are currently suspended, and 1 has temporary privileges, and that's a total of 656. Regarding activities, we have the new mobile MRI that's going to be installed soon that we're very excited about. For that, Dr. Brian Smith has been working with the radiologist and with the medical staff leadership to establish protocols for that. You know, until this point, the MRIs have all been done at Alliance Imaging across the street. They had their own protocols in terms of from everything from getting consent for contrast to applying the contrast. So we have to create all those protocols for the hospital inpatient imaging and outpatient imaging that's going to be run by the hospital now. That is an ongoing process that is going well and should be all in place with a little help of some emails and phone calls to get it done for next month for that MRI. The aquablation program is going well. We are close to 100 cases now, if not already there, total since we started in September of last year. We continue to get a lot of demand for it, and the patients have been getting good results and been very happy with that. We'll be getting surgery residents starting in January of next year, and we are preparing the medical staff office in terms of getting protocols, adding it to the bylaws, and for monitoring of those residents, and also excited about having them here. And that is all I have for tonight. Any questions?
Oh, thanks, Mark. Thank you.
Thank you.
Thank you.
This is the Service League.
Service League is next. Sheila?
Good evening, members of the district board. Again, a warm greetings on behalf of all the volunteers. I'm happy to share that in October, our volunteers continued their exceptional service across various departments. A total of 226 Service League volunteers contributed 2,007 hours to the hospital. On October 26th, we hosted a well-attended orientation, welcoming 8 adults, 13 college students, and 2 high school students. It's always wonderful to see new faces eager to support our hospital, and we are thrilled to have them join our team as they begin their training. Our gift shop was closed last week on Friday and Saturday as we prepared for the holiday shopping season. We were happy to welcome everyone back when we reopened on Monday, November 11th, for the annual gift shop holiday show. Thank you to all those who joined us in the hospital lobby that day for cookies and coffee, courtesy of the Washington Hospital Employee Association. Attendees also had the chance to enter a raffle and win some wonderful items. Building on our ongoing volunteer efforts, we are excited that more than half a dozen adults have expressed interest in volunteering in the Infusion Center and Washington Radiation Oncology Center. I anticipate completing their training by mid-December, preparing them to assist in these critical areas in the new year. We are also excited to announce that volunteers will soon be giving tours to prospective parents at the birthing center. Trainings for this new initiative has already begun, and we are working to finalize the details and set the exact start date for these tours. We are also looking forward to our masquerade sale, a 3-day event running from Monday, December 2nd through Wednesday, December 4th. This sale will offer an amazing selection of gifts, all priced at just $5, an excellent opportunity for staff, patients, and visitors to find something special without breaking the bank. That is the end of my presentation. I'll be happy to answer any questions.
No, thank you.
Looking forward to the masquerade.
Thank you.
sale.
Thank you.
We all have our
Thank you
flyers.
so much.
Yes.
We got our flyers and some
I'll see you everyone at the masquerade sale.
Thanks, Sheila.
Thank you. Dr. Eapen, I know that we have Dr. James McGuire. I know he also had to be on call this evening, and so I don't see that he is on. And so why don't we go ahead with the finance report, and then if he is able to join us,
Yes.
otherwise he will, we'll do it next month. But I know unfortunately he had to take call for somebody who had a sick child, so.
You're on.
Okay,
All right, Tom.
I will present the final September financials. Starting with the operating indicators, inpatient average daily census of 152.7 was short of budget by 20.7. Budget was at 173.4. On a year-to-date basis, we trail the budget at 153.6 versus a budget of 167.7 by 14.1. The combined average daily census, inpatient and outpatient, 165.5 on a budget of 187.1. So a little shortfall of 21.6. And then for year to date, we're at 165.9 on a budget of 180.8. Again, around 15 on that. Discharges were 886 on a budget of 994. Year to date, 2813 discharges for the first 3 months on a budget of 2836, so a slight miss there of 23. Patient days for the month of September came in at 4,581 on a budget of 5,203, so 622 shy of budget. On a year-to-date basis, we're at 14,135 patient days on a budget of 15,426. For outpatient observation equivalent days, we came in under budget at 383 on a budget of 410 by 27, and we remain positive to budget on a year-to-date basis through September by 68. Average length of stay was 4.99 on a budget of 523, so outperformance by 24 basis points. And on a year-to-date basis, we're at 522 versus a budget of 544, or a 22 basis point outperformance. Our case mix index, or CMI, for the month of September came in at 1.684 on a budget of 159. On a year-to-date basis, we're at 1.642 on a budget of 1.584. Deliveries came in at 141 on a budget of 136, so 5 more than budget. And on a year-to-date basis, we exceed budget by 34 deliveries. Surgical cases came in at 479 versus a budget of 537 We're about 10.8% off budget. On a year-to-date basis, again, it's a slight miss. We're at 1531 on a budget of, outperformance of 1531 versus 1510. Cath lab for the month of September came in at 183 on a budget of 199. And on a year-to-date basis, we're at 555 on a budget of 571. Outpatient visits came in at 8377 versus a budget of 8934, or about 557 shy. On a year-to-date basis, however, our outpatient visits are 26,340 through September on a budget of 25,883, or outperformance by 500. Emergency visits for the month of September came in 589 short of budget at 4,867. On a year-to-date basis, we're below budget by 807 at 15,179. As I mentioned, the surgical cases came in 58 under budget. The breakdown is in front of you on the slide. I would simply call out the other surgical cases comprised 45 of the 58, and then the vascular cases. Did you want to say anything on the vascular?
No. Vascular's, it's been falling behind the budget volume.
Yep. All right, cath lab. Again, the vascular is where the shortfall is. 8 were in peripheral, and then there's 10 in non-vascular. But you can see the cardiac, 8 in the cardiac. No, yeah, cardiac was 1 over, and neuro was 1 over. Mm-hmm. Pardon me. FTEs for an operating indicator, productive FTEs came in at 1435, which was outperforming to the budget, and non-productive FTEs came in at 202.7, which is pretty right on to the budget at 22.06. So when we look at the total FTEs, we came in at 1638.1, which was significantly under budget. Total FTEs per adjusted occupied bed, we underperformed the budget at 6.04. The lower the number, the better here. And the budget was 5.9, so we underperformed by about 14 basis points. On a year-to-date basis, it's much tighter, where the actual is 6.09 on a budget of 6.04. Getting into the financials, our final gross revenue for the month of September was $204,272,000 on a budget of $216 million, or about a $12 million deficit. On a year-to-date basis, however, our gross revenue coming in at $645.4 is greater than the budget by $8.2 million. Contractual allowance came in at 74.58% versus a budget of 75.19. And on a year-to-date basis, we are just ahead of our budget at 75.18 versus 75.21. Provision of bad debt came in at 178 on a budget of 184. And on a year-to-date basis, we're about 20 basis points better than budget at 1.63. So all in, the month of September, we came in at 76.36 on a budget of 77.03. And on a year-to-date basis, we are ahead of budget at 76.81 versus a budget of 77.8. Now for the GASB results, I'll take us to line 3. Net operating revenue for the month of September was $49.4 million on a budget of $51, or $1.6 million shortfall. And then operating expenses came in at $49.4, on a budget of 51.29, or a $1.6 million shortfall. So our net operating income for the month of September was $14,000 on a budget of $4,000, so outperforming by $10,000. And on a year-to-date basis, we are at $87,000 on a net operating income on a budget of negative $442, for a positive variance of $529,000. Moving down to the non-op and the non-operating income, for the month of September, we came in at $2.1 million on a budget of $643,000. And on a year-to-date basis, we're at $7.1 million on a budget of $1.6 million, so about $5.5 million of outperformance on the non-op income.
Tom, why do we keep getting so much of a positive variance with property taxes? Like that same thing happened last month.
Yeah, yeah. So it varies month to month, what we receive based on because that's the property tax that we're getting to pay off the GO. Yeah, pay down the GO.
So you think that's going to persist, that kind of variance?
At that level, the $890,000, no. Especially if we do refinance one of our GOs, our older GOs. But I do think it will start to tighten up, but it's not going to be exact to the budget ever. Net income. That's where we take the net operating income and the non-op income, add them together. We're at $2.12 billion for the month of September on a budget of $647,000, so outperformance by $1.5 million. And on a year-to-date basis, we're at $7.2 million on a budget of $1.2 million, so outperformance of $6 million. Now we look at it from a FASB perspective. And to your point, FASB says, do I have it at hand? The government says, am I expecting it? And so that's another reason that you see those numbers vary from time to time. We get to say what's there and not what we're expecting. Looking at net operating income here, we're negative $546,000 from a FASB perspective, but on a budget of negative $624, so we're positive $78,000. And on a year-to-date basis, we're negative $1.5 million on a budget of $2.3 million, so outperformance by just over $800,000. On the non-op income side, for the month of September, we underperformed by $27,000 at $893,000 for the month. And then on a year-to-date basis, we're at $2.6 million versus a budget of $2.5, so outperformed by just over $100,000. So on a net income basis, we're positive for the month of September by $51,000. And then on a year-to-date basis, we're positive by $1 million. And next, we go to line 5, which is the EBITDA. So if you look at EBITDA for the month of September, $3.4 million on a budget of $3.5 million, so about $51,000 shortfall on the EBITDA. On a year-to-date basis, however, we're at $10.3 million on a budget of $10 million, so we're outperforming by just over $300,000 on the EBITDA. And with that concludes my report.
Thank you.
I see that Dr. McGuire is here, so maybe before he potentially calls away, why don't we do that presentation, if that's okay?
Yeah.
All right, I'm going to take a few minutes and introduce Dr. McGuire. He is the medical director of the Special Care Nursery. Dr. James McGuire started at Washington Hospital in terms of as the Special Care Nursery medical director, where he practices neonatology. He's also a professor of pediatrics at the University of California, San Francisco, and he practices and teaches at the UCSF Benioff Children's Hospital in San Francisco. He received his undergraduate degree from Harvard, his medical degree from the University of California, San Diego, and a master in public health degree from UCLA, where he also completed a residency in pediatrics and a fellowship in neonatology. His work interests include team harmony and collaboration. Dr. McGuire is fond of the Bay Area, having grown up here, and currently lives in Fremont with his wife and 2 children. I also do just want to let the board know that recently Dr. McGuire unfortunately announced that he is stepping down from his position as medical director of the special care nursery. And you are going to continue to do your clinical work here.
Absolutely.
But I just want to say I was one of the people involved in bringing you here, and I was trying to remember exactly when that was. When did you start?
10.5 years ago.
10.5 years ago, all right.
Yeah, I remember you interviewing me.
Yes, with a whole group of people,
It was
so.
really very supportive and good questions, and it's been a great journey and great to work here, and other people contributed to dealing with complex issues and collaborations,
Yeah.
brought on the perinatologist and the diagnostic center and so many things that have helped our unit grow, and but sometimes there have been some challenges to make it all go smoothly, but many people have made that work. Even tonight, I just want to say thanks to everybody, Cheryl, and everybody reaching out and enabling me if I get called away tonight.
Yes.
At least I'll have her be a really good looking.
Yeah, I know, you'll be best looking and best dressed, but.
There you go.
And I definitely do want to thank you for the impact that you've made. You truly have, made a major impact on the tiniest of our patients. And, for us, your leadership has really been unwavering, and you have always looked at what's best for our patients and what are the programs that we need to work together to put those in place. And I think just mentioning your interest always in collaboration, you were always there to work together, whether it was with the physicians, the staff, the patients, everybody. And I truly appreciate that. And the work that you've done will have a lasting impact on this healthcare system. So thank you very much.
Thank you.
Yes.
Thank you.
Thank you all. I'm not going to cry. Not right now.
Did we change your mind?
Yeah. He's not leaving.
Yeah.
So that's the first thing I said, wait a second. All right, so we'll turn it over to you for your presentation.
Very good. Yeah, so this is the annual report of the Special Care Nursery, and already was stated what my roles are, medical director and so forth. Yeah, so again, this Washington Hospital established a partnership with UCSF in March 2014 to have UCSF as the physicians be involved with the Special Care Nursery. And so the physicians collaborate and work alongside the Washington Hospital nursing and ancillary staff. And the services include sort of all the care for stabilization of the newborn, respiratory support, including ventilatory support until transfer if they're really sick on the ventilator, initiation of this cooling, which we call therapeutic hypothermia for the brain, and then intravenous fluids and medications, nasogastric feeding, incubators, warmers, cardiorespiratory monitoring, things that we use for particularly premature babies and sick babies. Next slide, please. The Special Care Nursery, this slide goes over sort of what's been going on the last few years, and the one on the left shows the sort of average daily census, which is sort of bumped around from 2.5 to now in 2023 was 3.7, and it's probably going up a little bit more because we're something we'll get to later. But in any case, so that's our census. Our patient days have also, yellow is the most recent year, 2023, have gone up. And then the number of minutes stays around, varies, but most recently it's been around 200. And then the live birth is our biggest predictor of how many patients will admit, and that's been hovering around 1,440 to 1,500 for labor and delivery. Next slide. Transports out, we always want to keep babies, obviously at Washington Hospital, when we can provide excellent care here. But there are babies that are born, we're a level 2 neonatal intensive care unit, intermediate, which means that there are babies that are born really premature or really need a lot of care that we can't provide here, like ventilatory support or EEG monitoring for seizures or things like that, or surgery, which we don't have capability. We don't have a pediatric surgeon here. So those babies have to be transferred out to a higher level of care for efficiencies or purposes. And so we do that as needed. And so in the last year, 2023, we sent out 23 babies, and again, they would vary from premature babies that are like born well below 32 weeks or really small, or babies that are on the ventilator that need services we can't provide here. In terms of quality measures, we are an intensive care unit, so we have central lines, but we don't keep babies on central lines for long, fortunately, but we do have a very thought out process to try to avoid central line associated bloodstream infections. Many have worked really hard to make that successful, and we are successful once again that we don't have any central line associated bloodstream infections. We haven't for years had any of those infections, which is great. Updated services. So the pediatric unit, as I think the board knows well, closed in the beginning of October into September 2024. And so there was still a desire to see how the Washington hospital could support the community, and in particular the smallest patients. And we looked at what a special care nursery could help in that regard. And I was part of a task force with Terry Hunter and many others. And basically, Matt Nordstrom was our point person. He's a pediatric hospital medical director. And we identified a population that we felt we could take good care of here, which are the babies less than 28 days of age. And so those babies who can be admitted from home to the special care nursery, historically, again, they would be admitted to the pediatric unit, and now we're admitting them to the special care nursery. And we've had, actually, we made these slides, there's I think been one more just in the last couple of days recently, and so a dozen since October 1st. And things have gone well. There have been some challenges and a lot of policies and procedures and so forth to go through the appropriate committees and so forth, but we're providing phototherapy for babies who have hyperbilirubinemia, which is babies who are really jaundiced, intravenous fluids for dehydration, intravenous antibiotics for possible infections, and then babies who come in that are full infants, then we can use a warm incubator to help them. And that will actually help our census, because we'll continue to get those babies and so forth. So next year, the census will probably be higher than previous years, is my guess. Education and professional development. So we have multiple ways of doing this, and the case studies that were reviewed by multidisciplinary team members. We have the UCSF has helped us in terms of outreach courses for the nursing staff, nursing care, and so they identify with the nursing leadership what things would be best for the nursing staff, and then, for example, skill labs for procedures, and then stabilization for these critically ill neonates. And as I showed you, there were like about 20 in the last each year, and so that doesn't come up that often, and so it's nice to have a team that can help review and answer questions so that we can do that well. And then quarterly UCSF perinatal outreach program is something that we'll do actually on this coming Monday, and we pick topics that are interested to the obstetricians, to the pediatricians, outpatients, pediatricians, pediatric hospitals, and our nursing staff and many others to come and talk about issues that are relevant. And so those are led by UCSF faculty, and we'll, as I said, have one on Monday, the November 18th. And then the Association of Women's Health Obstetric and Neonatal Nurses also does training that the nursing leadership coordinates. Next slide. Next steps. So I've been saying this, so these slides are a little old, but we're still hoping. I didn't have as much gray hair in the middle slide, but we're hoping to get the reunion back going. But obviously, the respiratory illness restrictions have continued to be problematic, and obviously we don't want to have a gathering that results in a lot of infants and children getting sick from some cold or something. So we're still trying to figure that out and what makes sense, and I'm really glad that we're being careful, because a lot of gatherings have been problematic, of course, as everybody knows. But in any case, we look forward to having those happy faces and those celebrations when it makes sense. And then, of course, the intensive care unit of the new hospital are continuing to work on what does that look like and how to make that the best unit for the Washington Township. And those are the next steps, I think. And thank you. Yeah, so really that's our team of,
Darling.
yeah, those are a team of nurses. We had a Hawaiian theme some years ago, and many of the nurses and staff. Soledad, I think many know, in the middle there is actually, I think, on leave right now for an injury, but we just have really made the unit what they are, and my colleagues and many of us other people. So it's really been a great team effort to make all this happen. I think that's what those pictures show it. She's in love, but my wife doesn't know. I haven't told my wife.
Yeah, I just wanted to say that I just came from the bank, and I think probably one of your first patients, Gabriel Fernandez, who, son of one of our loan officers, she had to come over to the bank and she finishes her work. And so he is just about 10 years and I remember that it was really touchy, and he had to go into the touchy care nursery. And he is a strapping young man.
Oh, great.
Love to hear
Thank you
that.
for sharing. It's always heartwarming to hear those stories. I mean, actually, the reunion is always one of our favorite things just for that reason, because we see the kids come back, and of course, we don't recognize them. They're strapped. You were a baby, of course. But it's nice to hear those stories. Thank you so much for sharing that.
Yeah. Oh.
It's nice.
Yeah, James, I know him for, we know each other for almost 10 years, or more than, 10 years here. From the time you came, because I was a practicing pediatrician in the community.
Yeah, I visited you at your clinic, too.
Yeah, you have been there, and you have been a great help, and thanks all for your leadership. You're really a special, person, heading the special nursery.
Oh. Nice. Good.
And I think it'll be, too premature to say bye to you because you're going to be still here.
Yeah.
But it's been great, and thank you all for all the support from the board and so many others. Terry Hunter, of course, I deal with regularly, and I can always get Kimberly Hartz and so forth. So everybody has been great, and I really appreciate it. So many of you and Larry Cardinal. So. Yep.
We will have a reunion, and Terry will make sure that you come.
Okay, absolutely. Looking forward to it. Sure. Cool. All right. Should I stay, or do you want?
It's up to you in terms of we're gonna.
Okay, maybe
Yeah.
I'll go in case there's anything
Yeah.
else. So I won't do that stress.
Yeah.
I won't stay sharp all night long. Let's put it that way. No, but it's been great to be here, and thank you all.
Thank you for coming.
Thank you
Thank
very
you.
much. Sure.
Okay.
All right, I'm going to go back to the operations report for October of 2024. So starting with the preliminary total gross revenue, it came in at $222.5 million for October, which was favorable to the budget of $221.1 million by 0.6%, and higher than October of 2023 by 12.7%. Year-to-date, you can see that revenue was favorable to the budget by 1.1% and favorable to last year to date by 11.8%. And as I get into it, you'll see the favorability was driven by emergency department coming in at $3.6 million, cath lab at $3.3 million over budget, birthing center at $381,000, offset by a decrease in surgical services, room and board, and ancillary services. Moving on to trauma cases. We saw 179 for October, favorable to the budget of 110 by 69 or 62.7%. And year-to-date cases was favorable to the budget by 166 or 39.6%. Inpatient trauma cases of 40 for October was unfavorable to the budget of 69 by 42%, and the inpatient revenue per case of $193,000 was favorable to the budget by $13,000. Outpatient trauma cases of 139 for October was favorable to the budget of 41 by 98 or 239%. So we continue to see that same trend, more outpatients than we're seeing inpatients that we had budgeted. Moving on to the trauma cases by activation code. You can see of the total of 179, the breakdown of 7 alphas, and this is the highest level of activation, the most acute patients, followed by 59 Bravo and 113 Delta. In October, out of the 179 trauma cases, 52 were falls, 31 were motor vehicle crashes, 6 head injuries, and 90 others. They're classified in a lot of different areas. Moving on to the gross revenue for trauma, that came in at $14.9 million for October, and it was favorable to the budget of $14.1 million by $830,000 or 5.9%. Year-to-date revenue was favorable to the budget by $5.2 million or 9.6%. Again, looking at it's broken down by inpatient and outpatient. Inpatient trauma gross revenue of $8.2 million for October was unfavorable to the budget by 33.9%, and outpatient trauma gross revenue of $6.7 million for October was favorable to the budget of $1.7 million by 297.9% or $5 million. Then moving back to the total preliminary inpatient gross revenue. Inpatient gross revenue of $126.3 million was unfavorable to the budget by $1.8 million or 1.4%, but 19.2% higher than October of 2023. Year-to-date revenue was unfavorable to the budget by $5.5 million or 1.1%. And again, unfavorability in October was mainly due to room and board, ancillary, and surgical services. Looking at outpatient gross revenue, came in at $96.2 million, which was favorable to the budget by $3.2 million or 3.5%, and 5.3% higher than October of 2023. Year-to-date revenue was favorable to the budget by $15.2 million or 4.2%. And as you'll see, the favorability is mainly driven by ER, cath lab, ancillary, and offset again by surgical services. Our average length of stay came in at 5.15, which was favorable to budget by the budget of 5.21 by 0.06 or 1.2%, and the length of stay was lower than the October 2023 average length of stay of 5.22. So really looking at continuing to focus on that throughput. Moving on to our inpatient average daily census, it came in at 156.1, which was unfavorable to the budget of 170 by 13.2 or 7.8%, but again was higher than October of 2023 average daily census of 145.8 by 11 equivalent days. Now, I know we talked about this and has been looking at, as we know, inpatient trauma has been down, but the other two areas that we had budgeted that we haven't yet seen, we budgeted for higher respiratory cases that we have not seen those yet, and also higher OR vascular cases, which is another area. So those are really, you can see that that has been driving it. It's not meeting the budget. Looking at our discharges trend, October discharges of 984 were unfavorable to the budget of 1,012 by 28 or 2.8%, but were 15.1% more than October of 2023. Year-to-date discharges were unfavorable to the budget by 1.3%. And at that point, there were no patients that stayed over 30 days. So I do know we have one that's over 30 days now in November. Looking at our patient day trend, came in at 4,860. It was unfavorable to budget of 5,269 by 409 days or 7.8%. But again, looking at October of 2023, it was the patient days were higher than that by 7.5%. Again, as I mentioned, this was primarily driven by lower days from respiratory of 260 days, and then also our OR vascular of 117 days. And then again, also due to our trauma. That's really what's driving the patient days. Total surgeries in October of 548 were unfavorable to the budget of 550, so very close by 2 or 0.4%. But were 68 or 14.2% more than October of 2023. Year-to-date, cases were favorable to the budget by 19 or 0.9%. Inpatient surgeries of 253 were unfavorable to the budget by 10 or 3.8%, but 36.8% more than October of 2023. And then outpatient surgeries at 295 were favorable to the budget by 2.8% and right on and consistent with October of 2023. So here's the breakdown on the surgical activity. As you can see, in terms of orthopedics, surgery continues to be better than budget. And if you look at October of 2023, and more favorable than that. Really driven by, we had Dr. Shaw and Dr. Bonner that were over budget, but also our UCSF ortho trauma surgeons did 47 cases. So they were also very busy at this. And I know Larry has told me at this point they've done about 200, as of this month, about 200 cases. So they've been very busy. Neurosurgery was down by 9. Also, as you can see, vascular surgery was down by 19 cases, or 44.2%. Endoscopy continues to be better than budget, and then other surgery was below budget by 7 or 5%. Moving on to the cath lab, we had a busy month in the cath lab. We had 219 cases that were favorable to the budget by 21 or 10.6%. And were 26.6% more than October of 2023. Year-to-date, cases were favorable to the budget by 5 or 0.7%. Our inpatient cases of 119 were favorable to the budget by 3 or 2.6%, and 15.5% more than October of 2023. And then outpatient cath lab cases of 100 were favorable to the budget by 18 or 22%. And 42.9% more than October of 2023.
Nice to see cath lab coming back.
Yes, it has been busy, and so you can see as the breakdown of the cath lab activity. As you can see, cardiac cases came in 35 cases over budget. We also did 5 Watchmen during the month. Non-vascular IR cases came below budget. I will say Dr. Vo, our new IR physician, has been busy in the cath lab. She did do 18 cases. Peripheral cases were just under budget by 5 or 12.8%, and our neuro IR cases were above budget by 2 or 33.6%. Deliveries have continued to be busy, and they came in at 135 for October, which was favorable to the budget by 2 or 1.5%, and were 11.6% more than October of 2023. Year to date, deliveries were favorable to the budget by 36 or 7%. Also, our C-section rate for the month, we had 37 C-sections, or came in at 27.4% deliveries. Moving on to our non-emergency department outpatient trend, that we had visits of 9,510, which were favorable to the budget by 70 or 0.7%, but more than October of 2023 by 4.9%. Year-to-date, visits were favorable to the budget by 545 or 1.5%. The increase or the favorability to the budget were really focused on 2 main areas. Infusion center visits were 18.7% favorable to the budget, and imaging visits of 2,288 were 84 or 3.8% favorable to the budget. It was offset by cardiac rehab visits that were below budget by 16.8%. All right, moving on to our emergency department visits. They came in at 5,119. They were unfavorable to the budget by 481 or 8.6%. I will say we had a very high budget there this month. We didn't make it, but the emergency room was still very busy. And they were 2.2% more than the prior year. And then year-to-date visits were unfavorable to the budget by 5.9%. And really looking at the mix, we had budgeted more of the level 1 and level 2 visits, which were not as acute, and they were under budget, but really we saw a great deal more of level 5 and level 6. And really, we were 59% over budget for the highest level, and we saw 513 versus a budget of 297. So really, we saw much more critical patients coming through the emergency room, and you'll see that also with that mix in our gross revenue. So moving on to the gross revenue, as I mentioned, total gross revenue was over budget by 0.6%. As you can see, surgical services gross revenue was below budget by 6.4%. Even though they were very close to budget, the mix of cases, this impacted the total gross revenue. As you know, neurosurgical and vascular were below budget. Cath lab revenue, you can see, was about $3.3 million, or 29.3% favorable to budget. And again, cases were 10.6% over budget. Room and board was below budget by 5.5%, really trending with the inpatient volume being down. Again, birthing center was 11% over budget. And as you can see, even though we were below budget for the emergency department, our total gross revenue was above budget by 23.7%, or $3.6 million.
I noticed that. Why do you think that's so?
Yeah, and really, and that goes back to what I was saying in terms of the types of visits we saw. So we saw really a lot more than we budgeted in terms of the more acute and complex cases. So we were over budget there are different levels, and our 5 and 6 are the most critical patients that come through, and our level 6 ones were over budget by over 50%. So that really bumped, there's more gross revenue. So what we had budgeted was more on the lower basic visits, so either they're being seen elsewhere in urgent care or through other places in terms of it. So that's why the mix really played a big role for the emergency department. Moving on to our preliminary payer mix, this looks better than budgets in many areas. So we'll see, as you can see, that government-sponsored payers made up 72.5% of the total gross revenue. This was favorable to the budget of 74.3%, and lower than the prior year's percentage of 74.7%.
That's lower than it's been in a while.
It is. So, yep. HMO gross revenue was 3.1% of total gross revenue, favorable to the budget of 1.8%, and also higher than prior year's percentage of 2.5%. Our PPO revenue came in at 21.6%, again higher than the budget of 21.1%, and also higher than October of 2023. That came in at 20.9%. PA TRICARE gross revenue came in just slightly above budget at 0.9%, which is unfavorable to the budget of 0.8%, and then private pay came in at 1.9%, which was favorable to the budget of 2%. So we're looking at sort of what's making up that shift.
Why the shift in Medi-Cal?
In terms of, I think there are a couple of things. We are seeing, I know our medical foundation has been seeing more Alameda Alliance patients, and that also can be played in terms of it. As you know, we went to a one-county system, and we have basically Alameda Alliance is the only payer in terms of it here. We used to have also one of the Blues, and so they've taken on a lot of they've taken on all the managed care business in the county, and I know South County has taken on quite a bit, and including the medical foundation, so that probably has had some of an impact. I don't know also just, if St. Rose and any of those changes have impacted it too, but a lot of it I think is really driven by Alameda Alliance and the medical foundation seeing more patients. Looking at our preliminary productivity indicators, adjusting for volume productive FTEs for October were 33.1 or 2.2% favorable to the flex budget of 1490.9. Moving on to the non-productive FTEs, you can see that they were unfavorable to the flex budget by 10.6 or 6.1% at 184.8 FTEs. And then lastly, looking at our total FTEs, they came in for October at 22.5 or 1.4% favorable to the flex budget. If we're looking at our total FTEs per adjusted occupied bed, we came in at 5.95, which was unfavorable to the budget of 5.86 by 2% or 0.09 for FTEs. Radiation Oncology Center, you'll see that we had a busy month for treatments. They came in at 420, or 1% favorable to the budget of 414 and 15.4% higher than October of 2023. And if you go to the next slide, you really see that a lot of that's driven by the higher number of new patients and that were referred especially in August and September, and also some in July. So that has been really driving the higher number of treatments that we saw in October. Also for October, we received 39 new referrals from various sources, and we saw 35 new patients in the clinic. So again, the conversion at this point, 9 have converted to treatments, but others are still in that process. Moving on to the Medical Foundation, clinic visits at 18,041 were favorable to the budget in October by 402 or 2.3%, and 8.1% higher than October of 2023. Overall, our specialty care visits were favorable to the budget by 6.6%. This was primarily driven by our gastro clinic, and they were 353 visits favorable, and also the ENT clinic, which was 135 visits. We did see less visits in our Warm Springs clinic, and we have an open position there, and we have a new position that will be starting in December there. Moving on to Development Corporation, outpatient visits came in at 2,818, which were favorable to the budget by 417 or 17.4% for October, and 22.6% more than the prior year. Really, our 3 entities, the Washington outpatient rehab visits were favorable to the budget by 21.5%, or 375 visits. Our Washington outpatient surgery center cases were favorable to the budget by 3%, and our Peninsula Surgery Center cases were favorable to the budget by 30.1%. So, busy month for our Development Corporation entities. Lastly, going on to our days cash on hand, they ended at 123 days. It was a decrease of 9 days. This is really driven by having to fund 3 payrolls this month for both on the hospital side and supporting the Development Corporation. So that accounted for over $10 million in terms of that impact and 6 days. And also in terms of some of the delays we saw, 3 days accounted for some of the delays we saw with operating cash coming in, but mainly driven by the 3 payrolls that we had to fund. And then charity, there were 131,000, as you can see, in charity care adjustments in October 2024. Year to date, we were at 868,000. Any questions for the month of October?
Nope.
All right, I will continue to move on to the calendar, and I'm going to start with our November Employee of the Month, and she's Shruti Joshi, and she's our credentialing specialist. As many of us know, our medical staff services has been called the front door to patient care. Their role is both to introduce physicians to our healthcare system and to ensure that our patients are being cared for by fully vetted providers. As a credentialing specialist, Shruti, our November Employee of the Month, must verify each new physicians' degrees, certifications, licenses, and past experience. She takes her role very seriously because she knows that indirectly our patients depend on her and her team for quality health care. This is how she contributes to our patient-first ethic. Trudy's road to working in healthcare began through dentistry. She was a practicing dentist in India before moving to the United States. Once here, she wanted to learn about healthcare in the U.S., so she decided to pursue a master's in health administration degree. Living in the Bay Area, she was very familiar with Washington Hospital and enthusiastically applied to become part of our medical staff services team. Her manager, Jasprit Kaur, described Trudy as having an excellent work ethic and strong multitasking skills. There are times, especially during our ramp-up to our trauma program, when several physicians needed to be onboarded at the same time. Trudy was able to keep focused on the increased workload in both an efficient and professional manner. She is passionate about the quality of her work. She's a Fremont resident and enjoys spending time with her husband and son, and together they travel both within the U.S. and internationally. So congratulations to Trudy, our November employee. I will say the medical staff office has been very busy with all of the, as we can see, between a lot with radiology and teleradiology and trauma, so we truly appreciate all that they do. All right, I am now going to move on to the calendar starting with the month of October and some of our past health promotion and community outreach events. I just want to bring your attention, I think all of us know that we had a very successful Top Hat, 38th annual Top Hat. We had over 650 attendees, and we raised close to $600,000 for the state-of-the-art MRI. Can we go, did I miss or did you miss? We're on September. Yeah, okay.
You're on the wrong slide deck.
Oh, that's the first page of the slide.
September.
No.
It's October.
Yeah.
October.
Last month's meeting.
Yes.
Let's go with it.
I'll go. Yes, we have the card. So just,
Yeah.
I want to talk, yes, and then we were very much also, the other thing that happened October 17th, we had the annual Pink Think.
Yeah.
Pink. We had over 300 attendees that attended. Also, in October, I just do want to say our trauma team has been out and about in our community quite a bit, doing Stop the Bleed education, and they've been doing that in many different places. And Dr. Morrison on October 21st also spoke at the annual Totally Trauma Conference, and there were over 200 attendees there. And also want to just bring your attention to October 23rd, Dr. Asuko did an education session on treating carotid and aortic disease through endovascular innervation, and we had over 356 views for that. So, all right, we had sports medicine that did sports physicals at Newark Memorial High School, and they completed 59 physicals and donated over $1,000 back to Fremont Unified and Newark Unified School District. So very much appreciate the work that they do. Again, our trauma team was in the community. They was doing education at the Filipino Heritage event, also at the Newark Dia de los Muertos event. Dr. Steigel also presented about low back pain at Acacia Creek, and Elisa Curry, as we all know, our PT physical therapy director, did an education on falls and prevention on Facebook and YouTube Live, and she had over 368 views for that. So excited about that. And to just a couple of the upcoming ones. We have those. Again, November 17th, the trauma team will be out in the community at Stop the Bleed, doing Stop the Bleed training at the Woodwari Fremont Temple. We also do want to just mention a couple of other things. We will be hosting our annual holiday tree lighting in Washington West on December 5th. And then on December 6th, we're doing the newer tree lighting. And those are always a fun event. And again, want to make sure that the community knows about them. So those are some of the upcoming ones, and I know they will also be on our website too. So, any questions about? I'm sorry for not having them all there, but just wanted to go over those with you. We want to move on to our action items.
Yeah.
All right, in terms of our action item, I'd like to, I know that I wrote a memo that is in everyone's packet and would like to talk with the board a little bit about this. I also have a short presentation that I would like to give. But I do want to just turn the attention to the memo that is in your packet regarding my recommendation that the board of directors consider a parcel tax. As you can see through our financials that we've been presenting each month, we have made some good progress in those, but we really need to look to our future and make sure that we not only take care of our patients today and tomorrow, but for the next 50 years. And it's really important that we look at all possible revenue sources and just really wanting to continue to not only provide care, but to elevate the level of care. And, you know, one of the things that you will hear in my presentation is that we're one of very few district hospitals that at this point does not have a parcel tax. Yeah. I have engaged Olson Remshow. They are one of the leading political law firms in the state of California. Their memo is also attached to mine, and it really gives the details of how all of the requirements and the procedures for placing a parcel tax on the ballot. Also attached to the memo is really an overview of what a draft of what a parcel tax measure would look like. And they have helped to draft that parcel tax proposed measure. And I will go into more detail, but really what is being recommended or proposed is a 5 cents per square foot of building per year, and really not to exceed a total of $7,500. But you will see on average, most households would have to pay a huge amount less than that, less than basically $90 per year for that. So why don't I to just give a short presentation and run through this so that everybody is understanding that. And I just really want to start and talk about, as we all know, this community healthcare system was formed because our communities came together in 1948 and wanted to have local health care. And they wanted to not have to travel outside the community for care. And so they took the 10 years that it needed to raise the money to open in 1958 as a 150-bed hospital serving a community of 18,000. And as you know, since that time, we have grown with our community, and we are now licensed for over 400 beds, and we are serving a community of over 400 or 350, getting close to 400,000. But we're sort of at that time right now that us and many hospitals are, in really facing many unprecedented challenges. I think through the California Hospital Association, the number I heard, there are about 29 hospitals in the state of California that are on the brink of closing. And many hospitals throughout the state are facing the same things that we are. And you can see that as, the financial pressures in terms of salaries, or the labor costs are continuing to rise. We have to recruit and retain strong and competent staff, and those costs, as we compete against bigger systems, are continuing to rise. The technology is important for us in terms of serving our community, whether it's IS equipment or other medical equipment. Pharmaceuticals and other supplies are continuing to rise. And I think we all can hear almost every month there are new state mandates that are unfunded that all hospitals have to comply with. So, we're facing those types of financial pressure. Also with revenue, you can see that our Medicare and Medi-Cal overall makes up a lot of times between 72 and 75% of our cases, and they do not cover the cost of care. Also, our commercial payers continuing to be challenging to negotiate with them and get paid on that timely basis. And overall, we've had some challenges with losses over the last number of years. But I do want to say that, we have been putting many initiatives in place and knowing that we need to continue to focus on reducing costs, but on increasing revenue. You'll see that many of our service lines have continued to grow, bringing in that new revenue, and we do have a path forward, but we have to continue to look at other sources of revenue, which other hospitals have done, in order to be able to offer the community services such as trauma care. So, this just really puts it out there in terms of looking at our pharmaceutical and medical costs and how they've really risen over the last 5 years of almost 41%. And that's a huge impact in terms of it for us to continue to have to look at ways to cover that through increases of revenue. Go ahead to the next slide. So really, again, what we need to do in order to safeguard this community's asset of being able to provide not just the basic care, but that elevated level of care. So the trauma, oncology, neurosciences, we have to explore other sources of revenue. And as mentioned, parcel tax really is one of those options that we must consider. And as I will be talking about, it's continues that opportunity to preserve the future of our community healthcare system. And let's go to the next slide. And you can see on this one that basically we are in the minority. There are a number of healthcare districts that are around us that have some level of parcel tax. So what that means is they're getting an ongoing source of revenue from a tax from the county in terms of that for their operations, and we do not. And other county hospitals do also on a regular basis, but district hospitals are in that unique have that unique ability to do so, and we have not. And one of the things about parcel taxes, they could really help us in terms of giving us that ability to help us to look at what is needed for our operations. And these would be the areas that I would recommend that we focus on. Equipment for trauma, for being able to be prepared for disasters and other public health emergencies. We've gone through COVID. We don't know what's ahead with that. But we always need to be ready because our community depends on us to be, whether it's a natural disaster or any other type of emergency. Also, it can help us to ensure that our operations in the emergency department and in our operating rooms has the technology and the equipment that's needed. Also, in terms of ensuring that we can recruit and retain the appropriate staff. And also then looking at our ambulatory side and ensuring that our community, out in the community, has the urgent care clinics and the outpatient health centers that are needed. So really what I am looking at proposing is a parcel tax that is focused on fairness and looking at by design. And it would be a per square foot assessment that proportionately so smaller parcels would bear a smaller tax burden than larger ones would. And also understanding that commercial businesses and office buildings would also be impacted by this. And so we would cap those for larger properties, anything over 150,000 square feet. So they would be capped at basically $7,500 per year on that. And if you go to the next, you can see in terms of how it would basically, we looked at two options, a 4-cent assessment per square foot for the building, and that would bring in, as you can see, between $10.2 million and $11.5 million. And if you look at an average home in our district is about 1,791 square feet, that would mean that they would pay around $71.64 per year. So, and then we looked at it for 5 cents, and we really feel like the 5 cents would be the best option for us. And that would bring in 12.7 through 14.4 million per year. And again, that would just on average, it would cost our house, our community per parcel $89.55, so less than $90 per year. And the other thing that I am recommending is really looking at a sunset after 12 years. So then it would go back to the community in terms of having them say whether or not they want to continue it. That's the point. So going to the next, there are really two ways that we can place a parcel tax on the ballot, and you can see that. The district can file for the parcel tax on the ballot, and that requires 66.7% of voters to approve. The other way that this can be done is a citizens committee can gather the required voter signatures, and then it can be placed as an initiative on the ballot. And that way, in going down this method, it would only need a simple majority for approval by our community, so 50% plus 1. So those are really the two ways that we could move forward with a parcel tax. So this evening, I think it's important that the board consider really 3 options. Again, like outlined here, one would be placing the parcel tax on the ballot probably in November of 2025 and going down that, but again, it would require a 66.6, majority of voters to approve the measure. The second would be the board could table the parcel tax and see if a citizens committee would pick it up. I do know that there is interest in our community and in a citizens committee to work to get those required signatures, because then only a simple majority would be needed to pass. And the third would be basically to ask staff and myself to continue to look at studying the parcel tax measure. So I sort of see as 3 options before the board. I know Paul Kozachenko is also here this evening in terms of answering any of the questions in terms of legal questions that may come up too. He's worked closely also with Olson Remcho in terms of coming up with this, looking at what we can do and what the options are for the board. Are there any questions?
I have a question for Paul.
Yes.
If the board chose to go ahead and put the parcel tax on the ballot for November 2025, what would it cost the district to put that on the ballot? We don't get that for free, is that correct?
No, we don't. We don't. Whatever's placed on the ballot, there are some miscellaneous costs that they would incur, not very much. The major cost is the cost of the election itself, which you have to pay either way.
Whether you win or lose.
Well, but through petition or whatever, because the Citizens Committee is still the same, and it's what the county does is it figures out its total cost to run the election, and it figures out what determines to be an equitable apportionment to the particular entity. So I can tell you that I think the last time we had a contested election, if I recall correctly, don't quote me, but it was around $425,000.
So undoubtedly it would be higher than that.
It would probably be higher than that.
Mm-hmm.
And either way requires a number of signatures to get it on the...
No, if the board were interested in proceeding on its own, and you obviously have time, because as the memo indicates, it's 88 days before the election, the action that you would take tonight is to direct us to come back with a formal resolution for you to do that. That would be the motion for tonight. That's if you wanted to then proceed and put it on the ballot directly. If you don't do that, then the Citizens Committee comes back. What they do is they collect the signatures, and if they get the requisite number, which we believe is around 18 to 19,000, registered good signatures, that will all come back to this board, and then from that, you have to make a motion to basically put it on the ballot.
But then it's only 50% plus one.
But then, because it went that route, it's 50% plus one.
So a much higher probability that it would pass.
Much higher probability that it would pass.
Yeah.
Alameda County did this recently with, I think, Measure C. They went through the same route.
Yeah.
And other jurisdictions have, other public entities have, well, they don't do it. The Citizens Committee, group of citizens within the particular jurisdiction proceed this way, and they've been successful, and as the memo indicates, all of the challenges to this process have all been rejected.
For me, I think trying to get a 66 2/3% approval by the electorate is a very high bar in this era. Clearly, the electorate has changed. We've been very fortunate in years past where our bond measures have passed with a modest margin, and have been successful with those. Parcel tax is probably less likely to get a favorable view by the public. I just looked at the bond measures that were approved here locally in Fremont, New Haven, which is Union City, as well as Newark. And the bond measure in Fremont passed, I think, with only a 63% majority. Newark and Union City passed with just barely 66%. Now, all these measures required only 55% to be approved. But that just tells you that I think it would be a challenge to forward with putting this on the ballot, and I would favor a citizens' initiative as the approach which is most likely to succeed. And the other thing is clearly the community deserves high-quality health care, and this is a way to fund this. And that's probably the most important thing. And it goes back to what you were saying, Kimberly.
Yeah.
We've been doing this since 1948.
Yeah.
And hopefully the citizens will step up again.
Yeah. And I truly believe in this board, through your leadership and vision, has been working not just to provide care for tomorrow or the next day, but for the next 50 years. And that's important. And we've got to look at ways that we can do that to continue to have this sustain and this community model be here for this community.
Well, I think that the wise path is to not do anything right now. Continue to study, and the Citizens Committee is a very logical path, not only because it's a 50% plus one hurdle, but because the signature gathering effort creates a lot of information for the public to either sign or not sign the initiative. And armed with that information, then a better choice could be made by the public in the election, or if the signatures were to be gathered. So I think it's an excellent way to get the word out throughout the communities that we serve. And for that, I think that's the best course of action.
I agree also that educating while getting signatures is going to be so effective, because you're going to be creating advocates and then go to their circle, and I think the word will get out. And it means more when when that information comes from somebody that you trust in your circle. Well, I didn't know that. And I think the citizens' initiative with the signature gathering is so valuable in terms of just touching more people on a very personal level than reading a flyer or seeing a commercial.
Mm-hmm.
It seems it would make sense, at least at this point, to postpone direct action and wait for further education and further possibilities, see if those possibilities emerge.
Right. The Citizens Committee will go forward.
Yeah.
The citizens did that back in 1948.
Yes.
Yep, I agree.
Yeah, I think, just looking at this, one of the slides which said, changing landscape, I think, it's at the bottom line. I think I would probably add one more, what's next? Things are really, I don't know what kind of changes are going to happen, but, I think it's a no-brainer. I mean, 50% is definitely easier than 66. But having said that, I think, if you can educate the public about this closing of hospitals. I mean, there are so many hospitals that are closed in 10 years in California and across the country.
Right.
I mean, Boston, Arizona, the Steward Health System, some billboard or somewhere. So slowly kind of brainwash them and make this awareness. And then when you bring this, they'll say, oh, yes, I think we need this hospital. So I think that'll be kind of a primer. I mean, prime, all the citizens. And then when we come up, I think it'll be much easier. Yeah.
Especially now that we are a trauma center. And
our value is increased.
I think the public is just learning what that is and what that means, and I think is what Mike and Jeannie talked about as far as having the opportunity during signature gathering to educate the public is a wonderful opportunity to reintroduce this hospital to the community.
Yeah.
And garner their support.
Maybe we should try to scale up the signature gathering, because I think everyone knows science at least would vote for us. So.
Yep. Thank you.
Mr. President, I'd like to make a motion on that item for the board and see the response to that. I'd move that we postpone placing the tax measure on the November ballot. Additionally, we should instruct staff to continue to explore and study the issue as circumstances change, and that we should get a report back by perhaps July of 2025. Be able to move forward then at that point with what's going to be the best for the district.
I agree, and I'll second to your motion.
Rhodes.
Okay. Director Eapen?
Aye.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Passes.
Okay.
Well, any announcements?
No announcements.
Closed session? So we will now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want the members of the public waiting indefinitely for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She'll be happy to respond to any inquiries about the reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. Board will now adjourn to a closed session.
Thank you.
Thank you.